All right, welcome everyone. This is Sober Sunday with me, Simon Bevy. This is our 9th episode, believe it or not. We have been here in this conversation for now 8 weeks. This is our 9th week. We have had very interesting conversations the last 2 weeks. We were very happy with thousands of you that tuned in. From different places, even beyond this country, and a lot of feedback from you, questions from you. And we want to invite you again today as we talk about this stubborn COVID-19. A very interesting topic we're going to be having today, that you will invite your friends, you will host watch parties, you will let your friends know that we are on, and that we are going to have very good conversation about this stubborn COVID-19 that has impacted all of our lives. That's our discussion today. We're talking about the facts, we're talking about the social impacts, and we're going to have Reverend Wainaina, who is the provost of the All Saints Cathedral in Nairobi, share with us his own story, survival story, thrival story from COVID-19. So we're very excited to have everyone here. Look forward to this interesting discussion. And so let me introduce my guest today. I'm very privileged to have, I think, the choicest guests around this topic. We're so glad to have the CAS, Dr. Mercy Mwangangi. I think all of you know her. She has been on TV quite a bit of late, giving us updates. So CAS, we are very glad to have you here. Please go ahead and just tell us a little bit about yourself, beyond work, whatever you'd like to say, feel free to introduce yourself.
Thank you very much, Mr. Mbevi. My name is Dr. Mercy Mwangangi, and I serve as the Chief Administrative Secretary in the Ministry of Health. And I'm pleased to be here today to discuss with you, discussions on this COVID-19, the stubborn COVID-19, as Mr. Mbevi calls it. And really to just have, one of those discussions where we really try and, give you insight as to how government is responding to COVID-19, some of the successes that we've had as government, some of the challenges that we have as government in terms of pushing through this, and really to emphasize on the role that each and every one of us plays, and to also paint a picture for you in terms of what the next few months will look like. So I'm glad to be here. And happy to participate in this. Thank you, Mr. Mbevi.
All right, welcome very much, Dr. Mercy. And let me invite Dr. Andrew Mulwa. This one we worked together with in Makueni County. So he's my colleague in that way. We are glad to have you, Dr. Mulwa, but you also, besides being the ECM Health in Makueni County, there are other positions you play in the nation around the medical field. So feel free to introduce yourself and let us know a little bit of what you do.
Thank you, Reverend Bevy, for hosting us. We are honored and privileged to join you and the team to discuss issues of a disease that has turned the world ups and down, so to speak. My name is Dr. Andrew Mulwa. I am the Minister for Health in Makueni County, and I also chair the caucus of the county ministers in the country, and therefore I play a role at the intergovernmental mechanisms in terms of response to COVID-19, being a member of the COVID-19 National Task Force, and also participating in various fora for international and national organization structures for response to COVID-19. I am looking forward to giving insights on what the counties are doing across the country, and as we prepare to go to the peak phase of COVID-19, how, like CS Mwangangi has mentioned, each of us has a responsibility to do in terms of containing the disease. Thank you very much.
All right, thank you very much, Dr. Molwa. Last but not least is my very good friend, my pastor in many ways, and my colleague for a long time, the Reverend Sami Wainaina, Reverend Canon Sami Wainaina, the Provost of All Saints Cathedral, Nairobi. We're glad to have you, Reverend. We prayed for you when we heard that you were in this, but let me introduce you. I know you're going to tell us your story, but invite you to introduce yourself and tell us a bit about yourself. Reverend.
Sorry, I lost you. I know you've been asking me to introduce myself. Yeah. Thank you for having me. My name is Sami Wainaina. As you've said, I serve as the Provost of All Saints Cathedral, and it's my honor to be here tonight.
Mm-hmm. Well, I know you have a family, and I have been close to your family, so I'm glad to have you. So, yeah.
Yes, I'm married. It's good to declare. Yes, for the last about 22 years, yeah. And we have 3 children with Beatrice.
Okay. Thanks. All right. Well, we're glad for many of you already tuned in. Please feel free to send us any questions that you have for either of us or for the panel tonight as we start. And maybe any comments, feel free to let us know. And we also want to invite you to host watch parties. We can see already quite a few of you have done that, so that we may have a lot more people involved in hearing the message. So let's start right away, Dr. Mercy. If you'd allow me just to address you as such, and you can just call me Simon for the discussion. But Dr. Mercy, it's been a few months, and a very busy months for you, and of course the ministry and what you've been doing. I know there's a lot that is going on there. There are people are very happy for what the ministry is doing. There's some who don't fully know. There's some who wonder whether you're doing enough. Maybe we could start with you just letting us know where we are at when it comes to this coronavirus, and what the ministry feels in terms of confidence in handling this virus.
Thank you. Thank you, Mr. Mbevi. Just today evening, I was able to receive our update in terms of where we are and what we're doing. And you know, this afternoon, actually, the Cabinet Secretary chaired what we would call the millionth session of the NERC committee. And, you know, in this session today, we were having reflections as to where are we in the response, where have we done well, what can we pick up, and what does this next phase in terms of the pandemic response look like? And allow me by beginning perhaps to share, you know, with everyone who's watching really how it is, you know, Kenya has been able to effect its response. Primarily through an executive order around March. The president put together a team known as the National Emergency Response Committee, and this team is chaired by the Cabinet Secretary of Health. And it's a multi-sectoral team and, you know, a whole of government themed team that sits, you know, every week and is able to digest all the many pieces of interventions that are underway and is able to provide oversight and direction in terms of our response. And so today, during our meeting, we were able to reflect and, you know, really consider in terms of what has worked in the past 143 days in terms of our COVID-19 response. And they've been good successes. I must say, at the very beginning, in March, when we had our first case, a few may not know, but we literally had just 10 beds in the whole hospital that were designated for COVID-19. And the situation is very different, with almost about 13,000 beds across the country. And that's just sort of one little bit of the successes that we've had. We've been able to restructure our response to have a lot of participation of different stakeholders. I'm glad that Mr. Molwa was able to, in his introduction, mention that he is a sitting member of the COVID-19 task force. This is a task force that is chaired by the Secretary. And perhaps this is a task force that perhaps, is very crucial when it comes to the response. And in it, we have 5 arms of response. We have the first one known as the case management team. And this is a team that is set out putting in place what are Kenyans' treatment protocols going to look like, when it comes to administering different management pathways and interventions. This is a team that determines for mild COVID cases, this is what we're going to do. For moderate COVID cases, this is what we're going to do. For severe COVID cases, this is what we're going to do. And in this team, we also have, of course, our famous modeling team. We did see a few memes, a few of the past presidential meetings where people were looking for the experts, and the experts seem, sit in this. And this is a team that models out how a disease progression will look like in the next few months. And very crucial, we do also have, and I find it important to really highlight to Kenyans how we are structuring our response, because it's very well thought out. And it also is very similar and mirrors best practice across the world. So essentially our engine is very well calibrated and similar to that in the UK, similar to that different parts of the world, South Africa, name it. We have the second sort of big arm of response known as the Emergency Operations Center. And this is this is where we have, multiple screens put up across the wall. These are the teams who are able to sort of have a picture of what is happening in each and every county. This is the team that deploys ambulances. When we hear that there's a case in, Athi River, this is the team that then is able to dispatch a team there or link up with the county team in terms of ensuring that samples are collected and that then we are able to, carry on with the response. And then, of course, we have a very agile lab team, diagnostics team. And I know many Kenyans will have a lot of questions about testing, lots of questions about, am I a Kenyan to walk into a lab and get tested? We have a lot of questions on the validity of our COVID-19 certificates. And so I think we'll be able to answer this as we continue. We do also have a lab team. And then, of course, we have a capacity building team, a team that engages greatly with the county teams and with, our other frontline workers, such as the police force and the prison wardens. And this is a team that teaches you how you wear your mask. This is a team that teaches you how you sanitize. This is a team that comes to fumigate. This is a team that is able to sort of carry out the level of, capacity building. And then the final team, of course, would be the risk communications team. I think the team that has enjoyed most of the attention from Kenyans with all the different memes, you getting it, I getting it, us, all of us getting it. And the team that, drives the response. I sit in this team and I provide stewardship for this team. Together with the cabinet secretary, we're able to drive the communication agenda. We're able to feed off the surveillance that we get from Kenyans. And of late, we have been getting really, useful feedback. And just today, we do plan to approach our communications a little bit differently, revamp it, and try to particularly reach out to youth who are our new subject as we move forward in our response. So just in, just to put it in terms of summary, we have the NERC and this team really being fed by multiple technical working groups, consisting both of state and non-state actors. And so I'd say Kenya, in terms of structure, is well put together. And perhaps today we'll be able to learn more and have more discussions on then now the nitty-gritties. Thank you, Mr. Mbeki.
All right, thank you very much, Dr. Mercy. Already a good response. A few people saying we are very happy to have that information. At least it gives us some idea of how things are being managed. Let me come to you, Dr. Mulwa, before we come to, there are many questions coming up for Dr. Mercy, but Dr. Mulwa, there's been concern. Even people have called me and said, do you think the counties are prepared for this? You're part of the national task force, right? So are we to worry? There's been in the media severally, people have said, I think counties have lied about bed capacity and things like that. Are we to worry? You know, my mom is in Makueni and my family there, where you are at, but across the country, do you feel like we are ready to handle this as it continues to unravel?
Thank you very much, Simon. I would begin by saying you should not worry much, because so far, so good. We have not had a crisis, an overrun of the health system in the country from the beginning of the pandemic to this date. And I want to believe that if anyone says, I am 100% ready, not even the most developed economies in the world can actually be able to say that about this COVID disease. Because a new disease, of course, there is a lot that we are learning about how to respond, the capacity, and new evidence is changing how the practice. Like 3 months ago, all positive cases were being managed in facilities, or what is called institutional-based care, hospital-based care. That is not the case anymore today, because we have home-based care guidelines that were rolled out a month ago, and there are now many clients who are on home-based care. We also have issues of testing, issues of capacity building of the healthcare workers, provision of PPEs for the healthcare workers, things that 3 months ago were completely different. I would like to start by saying, at the beginning of this pandemic, when we had our first case in this country, in the counties, when we had the first case, I think Machakos, Nakuru, Nairobi, a few counties had a few staff that had been trained on anything, case management, sample collection, surveillance, all that. But with time, we have been able to train across the country. All 47 counties can confidently say they have trained human resource who are competent enough to handle the whole spectrum of COVID-19 management, which is a good. At the beginning of March, I remember March 4th, we had a meeting with the cabinet secretary as the Council of Governors. And our thinking that time was each county should just prepare 5 to 10 beds for handling COVID-19 cases. And when we left that meeting, we were like, yes, we are going to do it. And I remember when I got to Makueni, I was able to identify some 52 beds. And according to me, I was doing 10 times the expected. That is not the case today. We realized with the epidemic hitting the country that we actually needed more beds from the epi-modelings that have been done. And now the whole talk of the country is we require about 300 beds. There was a lot of sensation about the use of ventilators earlier on. And the science seems to change that ventilators are not as are not as important as it was initially thought, and therefore having oxygen and all that is all that you require. So we are learning about the disease. We are learning about how to respond to the disease, and I believe the counties have been able to effectively manage the cases. We have had 44 counties so far have cases of COVID-19. As far as I'm concerned, I am not aware of any county that is overwhelmed. Of course, we are starting to see signs of a health system being overburdened, especially in the county of Nairobi, which was the county that has been the hotspot or the epicenter of the disease for quite a long time. And therefore, as we now build the capacity of other counties, I am sure that the health system of this country will be able to manage. Then the most important thing, which I think I'll also mention as we continue the debate, is the role of the citizenry, the role of the ordinary mwananchi in response to COVID-19. It is as important as the beds. It is as important as the ICUs. It is as important as the trained healthcare workers and the PPEs. Thank you.
Yeah. Well, it's good to hear that. And we're going to come to that, where I think there's a lot of attitude of serikali saidia. But we also need to know, how do we saidia ourselves? And Dr. Mercy Stephen J. here, Mwaneki says, Those are many teams. We are glad to understand that. Good job. That's what he says. Moeni Mengo says, we need to discuss a lot more around the competence of testing COVID-19 by medical labs. I think there's been a lot of concern around the credibility of the tests. Maybe Dr. as we come to Reverend to start giving us his story. Reverend, we are coming to you in a minute. Dr. you could just say briefly, can we trust these tests? And why is it sometimes we have conflicting tests?
Right. Thank you. Thank you, Mr. Mbevi. And I think that indeed is something that we need to discuss. And I'm happy to, shed some light and share some insights into our testing strategy. So when we began, perhaps back to basics, when we began our COVID-19 response in the country, we remember we had to fly out samples to South Africa. And in a very short, period of time, we were able to jump from 2 labs to about 29 labs currently in the country, and constantly working to increase, the lab architecture. It becomes important for Kenyans to understand that COVID-19 really, even by virtue of its name, is a new virus. And that it's a virus that, as Dr. Mulo has said, we are constantly learning and having new emerging evidence. Now, when we set up our labs, we stand by the competency in terms of our human resources. And it's always important because testing is highly scientific, as you would expect. And so there's different elements that go into a successful outcome of a test run. One, of course, is you have to have human resources that are competent in that they're able to run the machinery. Remember, this was a new virus. And so the assays that came in and the methodology of conducting the test required capacity building of the lab technicians to ensure that they know what they're doing. Secondly, of course, you require the machines. So these are the PCR machines. And luckily, the country in the past years has made investments in being able to have PCR machines. This is the very same machine that you use to test for HIV. So every time you get someone testing for HIV viral loads, it's the same machine that you use. It's almost a machine that's able to type the DNA of a virus or the RNA of a virus. And so you have to ensure you have the right machinery and that the machinery is serviced and is working correctly. And then the third part of this is the input. So when you're taking in, a run for a machine, you have to ensure you have the right reagents and the right assays. And the fourth element is that the sample has to be taken correctly. Now, if we are to look at science and to be able to statistically compute any given exercise, even perhaps picking red balls out of a big jar of red and blue balls, there's always an element of error in terms of you being able to sample and pick out the balls correctly. And so what we've seen and the studies that have come out have shown us that the sampling technique, the technique of actually putting a swab within your nose and your mouth to take the sample has to be done very well, else we'd be able to, miss, a possible case or perhaps identify a non-positive case. Every time you're running COVID-19, so far, what we've noticed is that we have a set number of, let me call them, testing kits. So we have testing kits from Roche, we have testing kits from different companies, much like the same way you have a TV from LG, Sony, Sanyo, and all the different brands. So we have about 8 accredited testing kits in the country. And these testing kits then use the assays that are attributable to that testing kit. And forgive me if I'm being technical, because really the answer to your question is very technical. So what happens is, how do we tell, a case is positive? Ideally, when you run a COVID test, there's usually a graph that is drawn using a process known as chemiluminescence. And a graph is drawn, and you should be able to see 3 curves coming out of the graph. And what we say would be a confirmatory positive test is if you're able to press 3 lines. And that means that those 3 lines have been able to compute the 3 genotypes of coronavirus. And so what is happening is that we are having a few variations. And when talk to our experts have explained the variations as follows. One, there could be purely sampling errors in terms of the person who actually took your swab. Two, there could be differentiations in terms of the assays, the testing kits that are being used in the different labs. So for example, lab X could be using BD, lab Y could be using Roche. And these differences in testing kits can actually bring variation. However, the most important thing, which I think Kenyans need to know, is that when we review our systems, and especially our external quality assurance system, which we've put in place, so a mechanism to ensure that I'm able to take samples from, say, Lancet, and I'm able to cross them with Kemri and NIC and ensure that the result is standard. Our system tells us that so far, slightly need to, improve on any, should I say, laboratory errors. However, we do stand by our tests. They've been done. And then there's also a key element, as Mola will tell you. We are noticing that depending on where you are in the disease, in terms of your progression of disease, the load of viruses in your system can actually affect your results in terms of your testing results. And so it's a new space, it's a new field, but I want to give confidence to Kenyans. We are on it, we are well seized of the issues. Just, I think probably next week, there'll be another round of external quality assurance to be able to look and see and validate the lab processes. But that being said, and not to really put a damper on this, whether your test is positive or negative really is just a reflection of that time. It's just a reflection of Mercy is positive at Sunday 9:45, or is negative. I could very well be positive tomorrow because of my interaction with the populace.
Okay. Well, thank you very much for that. It's appreciated. Thank you to all of you bringing in a lot of questions. I will definitely not be able to answer all of these today, but let's go to Reverend Wainaina, the provost. There are lots of people waiting. There are some who have said this thing is a joke. It's not real. I've encountered people like that who have said this is just a conversation. It's not real. Provost, did you have this COVID-19, and what is your story? Maybe you can start us off and we'll keep coming back to it. Provost, you need to unmute yourself. Sorry.
Thank you very much, Pastor Mbevi. I've had in many talk shows that I have done now since I recovered from COVID-19. In one of the talk shows, somebody said, you guys are being paid to by the government because the government wants money. And well, I don't think I would be paid to be sick, first of all. When I got admitted in Aga Khan Hospital, I don't think the government paid my bill. So to claim that people can be paid so that you can be sick and come out of it is a big lie. Just like HIV and AIDS, if you don't believe there's COVID today, you realize you have it when you lose your mother, your father, your brother, your sister. And that's how HIV and AIDS came to us. And I think we need to learn from other pandemics, because COVID-19 is not the only pandemic, that it is possible for us to pick lessons quickly from the HIV AIDS and run with them so that we can save more and more lives. Just this week, we have lost a senior clergy of the Presbyterian Church. We were together in the university. That's somebody I know personally. Dr. Oko again, and it's in public domain, has died. I don't know what we are waiting to know that truly COVID is real. Maybe one of the things that Dr. Mulwa and CAS Mwangangi will talk about is what is it that Tanzania know that we do not know? Because today I met somebody in the afternoon who was saying, hey, Tanzanians are our neighbors here. What is it? why is Kenya different from Tanzania? Anyway, I leave that to the doctors. But anyway, to confirm, and I'm well known, I'm a public leader. I got COVID. Towards the end of May, I started feeling unwell. I remember it must have been on a Tuesday, the last Tuesday of May. And for me, it was a cold. On my way home, I got into a clinic, got some amoxicillin and some antihistamines and some Panadol, and I went home. But the night wasn't good, but the following day, I needed to be in the office. So I was coughing. I was coughing by morning. And I thought, this is a bad flu that I have. I've had flus that are bad, especially when you travel. But by Wednesday, 3 o'clock, I wanted to go home early. I was feeling sleep. I wanted to sleep. I felt my body was getting very tired. And because I didn't have much in the office, I came home. That was the last time I was in the office. And I stayed getting sick and getting well. It took me almost a month and a half. So almost 8 weeks of absence in the office. So truly, if I was paid, I don't think with my nature of work, I would have been away. I have a demanding job at all things. Anyway, to cut the many stories short, maybe the questions will help me to clarify. On Thursday, having left the office on Wednesday, on Thursday, I couldn't go back to the office. I had to delegate.
I think we have lost Reverend. There must be some issues. Okay, welcome back. We had lost you briefly. So you were talking about that Thursday. You were not. You can go ahead if you can hear us.
Yes, but yes, I can. Thanks. By the time I am in on Friday, my body temperature was so high, and I remember going to the hospital at night with temperatures of 39 point, almost getting to 40. And I was feeling very sick. I had to get an injection. My doctor told me to do a number of tests, but some I couldn't do where I am. I went to the main hospital on Sunday afternoon, and I was done some pneumonia, and I was given some strong antibiotics, came home, and I was told, wait for a call after they took my COVID test. So on Tuesday morning, I'm called to go to the main hospital. And to me, it is from the Wednesday I left the office, it was like rolling down the cliff. Things worsened and worsened every day. And I remember the Monday prior to my admission on Tuesday, because I was admitted on Tuesday, 2nd of June, I was so sick here at home that I would have easily collapsed and died. Doctors will tell you here that your inflammations go very high, that you're not able to fight any disease. And that time, you can easily die. And especially with the pneumonia, you can easily collapse because you don't have enough oxygen. So as I said, it was like going down the cliff. On Wednesday, I felt so sick, I had to ring the bell and call the doctor. Fortunately, that morning, they had taken my blood samples, and the doctor said, Sammy, you're very sick. Your inflammations are very high. You need to go to the ICU. And that's when I saw the reality that it's very easy to lose your life, like a joke. And I was in ICU for 5 days. It was 4 nights, but 5 days, because I spent the 5th day, but I didn't spend there. Basically, what I was receiving in the ICU was oxygen support. I also took 2 tablets, and the doctors can explain about it. It's to lower your inflammation. They are called dexamethasone. The doctors were very good. They were able to walk the journey with me, explaining, telling me I'm sick, but they are doing their best to help me. The first 2 days in ICU were hell. I couldn't think. I was conscious, but your brain consciousness is so low that you can't think much. You can't even lift something. And I was encouraged to turn and sleep on my belly to allow oxygen to flow. Imagine you thinking of figuring out, how do I turn? Because you're so sick and weak. And so those are the management that I received in the ICU before I went back to the ward. But let me end there in case there are more questions.
Well, thank you, Provost, for sharing that story. I'm going to get back to you. There are already some questions coming up in terms of the lessons you learned out of there, and what else you'd have done differently in terms of going to hospital. Would you have gone a little earlier? What else should we do? But let me come to you, Dr. Mulwa, so that we know you're still here. Someone is asking, hydroxychloroquine, does it really work? And are we trying it out? Because there are a lot of video clips from the US and other places that are saying someone is hiding the truth from us. Does it work? And then secondly, Dr. Mulwa as well, you can tell us, we now have home-based care. Being told, go home and just take care of yourself, make sure you don't mix up with people. Is that working at all in the counties? Is there guidelines and support from the government, the county governments and elsewhere to make sure that that is really working? Because someone here is very concerned about that. Lillian Mwashuma is really concerned. So Dr. Mulwa, go ahead and mute yourself and you can let us know.
Thank you very much, Reverend. I think I'll start by the hydroxychloroquine story. There are a lot of myths and theories about this drug. And last week, there was a viral clip from the United States of America on someone who was saying that this drug works, does need research. He has seen many. I think like all medicine, and that's why the practice of medicine is evidence-based. And evidence-based means there is some good research that has to be done on any commodity, on any device, on any equipment that is going to be used on human beings, and has to meet certain standards and has to go through certain processes. I think the story of hydroxychloroquine has been mentioned, and there have been many studies that have been conducted in management of COVID-19. And WHO, I think, advised, and the experts would also would give more information, advice against the use of hydroxychloroquine because it was found to have adverse effects that outweigh the benefits that one would get from it. I am a bit worried because I work with communities and I engage a lot of members of the communities, and I'm learning that there is an attempt to self-medicate hydroxychloroquine by citizens of this country. And that is really a worrying trend because hydroxychloroquine will give you adverse effects, and maybe the one that will bring you down faster than the COVID-19 that you are attempting to fast. If someone is taking to prevent, to get the disease, or to treat the disease by self-medication. So, and I think like CS Mwangangi has mentioned, there is a team that is working on the treatment protocols for this country. And therefore, in terms of which drug, when should it be administered, in what dosage, to which clients is a subject that is purely very, very technical. And I would personally make a personal appeal to the citizens of this country to avoid self-medication, as it could have bad outcomes on themselves and people that they love. I think for that, I will end it at that.
Okay.
But the issue of hydration, the issues of if you are positive, you need to keep hydrating. The issues of good diet, the issues of vitamins, those are good for health, and therefore I encourage, and the ministry has been clear on that, you need to have healthy diet and all that. But for medications, I personally advise that therapeutic agents are left to clinicians and technical people. The issue of home-based care, yes, indeed, it's working. I think I can give the statistics for Makueni. Of the 32 clients that we have, active clients that we have today in Makueni County, 6 are on home-based isolation. The healthcare workers, healthcare professionals have been trained on the assessments, and one has to go through an assessment to meet a criteria that has been developed by the National Ministry of Health to ensure that one meets the threshold for home-based isolation. And once you meet that criteria, the health workers will constantly keep in touch with you, monitor you throughout the days of isolation. So the whole difference is we will not offer you the hotel services, which is the accommodation, the hospital bed, the hospital food that is that you are supposed to get. But in terms of management, and you will not be able to take your temperature every 3 hours, you will not be able to take your pressure every 3 hours. But in terms of close monitoring by health professionals, it is happening, and the counties have built that capacity, because ultimately that may be the way to go in terms of as the numbers continue to grow. We are likely to have more people on home-based care, and therefore it is working. It is not everyone who qualifies for home-based care, and we are working closely with the ministry to even think beyond the home-based care, because there are those households that, yes, do not have the capacity to have home-based care. As we expect to have more numbers, we are already thinking about community-based care, where we have a church, we have a library, we have a facility within that community that can easily be converted into a community place for isolation, that if I fall sick and I'm not able to meet the criteria for home-based care, I can go to that community place where I can be able to get a community-based isolation as a way of managing the health system. Because in all the efforts that we are doing as a country, the one thing that we do not want is for the health system to be given a choice to decide who gets treatment and who does not. So we don't want to overwhelm the healthcare system, and that's why we are adopting some of these modalities to ensure that it's only the numbers that the health system can handle that enter into the health system per se. That would be my remarks for the two questions that you had asked, Bevi.
Okay, thank you very much. Actually, there's a Lydia Diho who says, karaoke, who says, home care works, I'm on home care. I think she was only saying the concern was how you check out whether the homes are ideal, but I think you answered that already. So thank you very much. 3 questions for you, Dr. Masi. There's just so much coming in, and we may have to do this again next week. I don't think we have enough time, but there's someone who is concerned about the international flights. Stephen is saying with that opening up, we're going to import many more cases. We are sure that it's safe to travel or to interact with people who have traveled in. And what's the government doing about that? And then I think my own question is, before I go to one last one, here is, are we getting out of the woods? Is this thing peaking yet? Where is the curve? You know, we've been told by August we're going to get to the peak. So we should expect things get better. Thereafter, we're already seeing in Mombasa, the cases are becoming less and less. Is it lack of enough testing, or are we truly coming to a peak? And we should expect that things are going to be better. And then there's a Tabitha Ogango is saying that grieving families. I think she has been part of grief because of loss of relatives, need care. And she's just wondering whether the government is aware that some of the practices imposed on this quick way of burying relatives is leaving a lot of families not in a good place. Your comments, Dr. Sorry to unmute. And
thank you. Sorry about that. So thank you, Mr. Mbele. I'll jump into those three questions, but before I do, I think it's necessary to really add on to what Dr. Mulwa has said regarding hydroxychloroquine. And just to Kenyans that, when the case came in and, as early as today, I received messages from a few people, asking me, are we trying this out? Is this part of the regiment? It becomes important for us all to know that there's actually a very, very rigorous process that is underway, not just in Kenya, but globally, before a drug is actually enlisted as part of the, for COVID-19. And what is interesting, and I'll share this with you so that you can share it with your members and the people in the audience, is that I'm just looking right now at the latest results that we have from hydroxychloroquine, and these are from 4 studies that were done using what we call the gold standard of evidence, which is a randomized controlled trial. We call that RCT, and it tells us some profound things. That, for example, hydroxychloroquine was not able to show any difference when it comes to deaths. So what this means is that they had people who were on normal care, and they had people who were on hydroxychloroquine, and at the end of it all, there was no change in the deaths when it came to hydroxychloroquine. Secondly, really important, and this was in the video that was circulating, is that, again, using a randomized clinical study, controlled study, they were able to have a group of people on normal care and have a group of people on hydroxychloroquine. And the group that had a hydroxychloroquine did actually had normal viral levels. So there was no decline in the virus that was circulating in their bodies. Again, giving effect to, no positive effect of hydroxychloroquine. And so it becomes important for people to realize that there is a mechanism and a process, and not just a Kenyan process, but a global process that we have to trust. And so as it stands, and as government position, at least Kenyan government position, is that we do stand by the WHO trials, that this is not a medicine that we shall be putting on to our schedules. In terms of the other questions that have been asked with international flights, again, to provide more clarity, that yes, we were able to open our skies yesterday, and we were able to share a list of countries. And again, I can share that with you in terms of the official list of countries that are allowed to come in. And this was after numerous discussions, not only within Kenya in of itself, but with the East African community, but globally, with the international community, to determine how are we to ensure some form of normality and continuity in air travel. And so what we did under the guidance of WHO is that we were able to come up with a criteria that determines entry of people into a country. And what has happened is that all the countries in the world have been grouped into categories. So we have low risk countries, we have medium risk countries, and we have high risk countries. And that categorization is based on the current evolution of disease in those countries. And the good thing is different studies have already been done where we've been able to look at the coronavirus in Kenya, the coronavirus in China, the coronavirus in America, and to ask ourselves, is this the same strain? And what I can say right now from our own internal studies and studies from different countries, it is the same coronavirus. So you would not be importing a new type of strain or a new kind of coronavirus. So after categorizing the countries into the 3 risk levels, we were then able to ask ourselves, how do we reduce the most, should I say, risk of importation, or how do we control for it? And so, for example, if we look at Kenya and America, we are actually on the same risk profile. And this is a risk profile determined by WHO and not ourselves. And because we're in the same risk profile, the advice from WHO is that we can therefore allow for travel between the two countries, but there are caveats that people coming in would need to have a COVID-free certificate that is at least valid for 96 hours. So done your test 4 days prior to travel. And when you come in, there would be exemptions for similar risk profile countries when it comes to quarantine. And this is an evolving situation. So for example, if you're coming in from, one of the less afflicted countries, say Lesotho, which has a very low risk profile compared to Kenya, then you can imagine that, the person coming in wouldn't pose a greater risk to us because they're on the low end of the profile. And so just to give comfort, this was not a purely Kenyan decision in the sense of, wanting to open up the skies. It's actually something that is being mediated at the WHO and by, the agencies that control international travel. And we are confident with the measures that we've put in place. We will still run the home-based quarantine and isolation procedures as people come in terms of their risk levels and their evaluation. In terms of, the question on, and maybe I'll touch on the grieving and end on the other one. Yes, indeed. Again, a new disease with emerging evidence. I must say at the beginning of the pandemic, we were able to, relay our response when it came to dealing with diseased bodies and in relation to Ebola. And using evidence from the Ebola scout at the Congo DRC, we were able to then customize what the guidelines would look like when it comes to barriers. The good news, perhaps I can say, is that we've had a recent advisory relaying to us that the risks of transmission from both actually reduced. It's very minimal, especially is able to undergo the treatments that it should in terms of mortuary treatments. And so we're reviewing our protocols to see then how do we, translate this in terms of our cultural practices to be able to give comfort to families who lose loved ones. That being said, as government, I feel we are duty bound to protect the citizenry, and so it becomes important sometimes to bear with the inordinate circumstances that we face. I actually attended, a COVID-19 funeral, and it was really, staggering and jarring how everything was done, in a hurry. And so, with a new advisory, there are teams, pathologist teams, who are looking to see how can we perhaps make more leeways for adaptation of our cultural practices, but always remembering that, again, duty bound as government is that we want to protect you and we want you to be safe. The last question on are we getting out of the woods is very interesting in terms of, Dr. Mulwa started us off very well when he said that every new day we have emerging evidence. And it's important to understand that really we are in unfamiliar territory. There are things that we know as factual in terms of the disease, but every day there are new unknowns that emerge from the disease. As it stands in the country, when we look at our modeling, when we look at our data, we do see the situation, climaxing between August and September, and we see a deepening of the curve around February next year. So we are in it for a while, for the next 4 months. But that being said, we never know. We never know. It really is an area of unfamiliar dealings when it comes to COVID-19. But one interesting thing is that, and Mulwa said it, really at the end of the day, each and every stakeholder has to play their part. And, I've seen a lot of people, go back and say, Serikali's idea, government should do more. But it becomes important to realize we really are the social vaccines. At the end of the day, if you keep away from people, if you maintain that physical distance, if you wash your hands and you mask, you're actually helping us in terms of reducing transmission by 80%. And that's impact, 80%. So everyone who's walking around, literally, just think of yourself as an 80% social vaccine. And this fight, we do need you. I think we've been very open and clear as government that really we are depending on individual responsibility as we move this fight forward. So thank you, Mr. Mbebe.
All right, well, thank you very much. And we're going to get back to you I think just to say to all of you who are watching, many of you, so many questions, hundreds of questions here and comments from many of you, some of you from outside of the country. We're very glad to hear. Definitely, we're not going to be able to cover all of this, but we will, I think, repeat this next week and be able to answer more. Steve Karaoke saying there, great information. Someone still insisting, I think it's if there could be an official statement soon just about some of the clips that we are getting from everywhere that keeps confusing Kenyans, especially about the drugs and what is true and what is not. Someone asking what's our risk category right there. I think there's a question about private testing centers where people can voluntarily go for testing, and whether those are enough for people to know where to go in case they have any. But we're going to get back to you, Dr. Molwa, and we're going to be asking, I think there's a big question that has come up over and over again. Asymptomatic people, what is it we should do about them? Are they not just carrying the virus and spreading it and they are not aware? What's the advice to the population? But let's come to you, Reverend, and ask you. Deep story that you shared a little earlier about your experience and what happened there, but we want to ask you, are there some lessons you learned during that time? And we hope your entire family is okay, that they did not get into trouble around that time. But what are the lessons that you would tell us as someone who has been there and come out by God's grace? What do you tell the rest of us? Some lessons learned as you unmute yourself.
Let me first confirm that when I got COVID-19, my family was affected. I have an echo.
Yeah, I think there's an echo. Is your phone on?
No.
Okay.
Yes, but let me check again. But anyway, just to say, no, my phone is not on. Yes, but just to say that my family was affected by COVID-19, but they were asymptomatic, and the doctors will be talking about that. And they had home-based care, and so they are all well. They were all declared COVID-19 negative. Let me say, somebody has asked today whether I should have done things differently if I knew. And I will say, yes, that's a great lesson. I wish I had gone to hospital earlier. I stayed for over a week, struggling with something I didn't know what it was. And doctors, again, can confirm this. Those people who go very late to seek medical attention are at a higher risk of death than people who go early. When I was sick that Wednesday, the window between Wednesday and Friday, I keep wishing I went for a COVID test. My wife kept saying, jokingly, this is COVID-19. And I denied vehemently, saying, I have been very careful. I have not interacted with people much in the office, and I have my mask, I have sanitizers, and I have kept my distance. So I kept denying. I wish I went between Wednesday and Friday. So what am I telling Kenyans? If you feel unwell, don't deny first. Go to the doctor. The doctor will be able to eliminate and say, by having the test, just like any other disease, when the doctors do the test, they are able to tell you, it is not this. Let's look for the reason. And so I want to think people who have been affected most severely are people who have gone to hospital sometimes too late, especially starting to have low oxygen. So indeed, that was a great lesson. I shouldn't have waited too long. But by God's grace, I was able to go. But Pastor Mbevi, while I was in the hospital, my heart went to the poor people. About 50% or more of Kenyans are poor. And I don't know what Dr. Mwangangi would say. How many of Kenyans can access good health care? I don't know how the public hospitals look like, but I sympathized with, I said, I'm in a better hospital. I know I'll pay more money, but how many Kenyans would be sick at home and they are not able to access good medication? Number two is about home-based care. How do we really assess the ability for those families to feed themselves, because they depend on daily wages to feed themselves? So you can imagine the breadwinner having been affected. How do we provide for them clean water and proper dieting so that they can recover quickly?
Well, we're going to come to you, Dr. Mulwa, and you're going to maybe answer some of the things that I've raised up randomly, but also give us advice generally what we need to do. But before we go then Dr. Mercy, the concern of the Reverend is the poor and what they are able to do, but also there's many texts that we have received here of people talking about the anxiety of waiting for too long, 1 week waiting for your test results. Anything the government is doing about that, the poor, and someone else had also asked about the highly populated estates in the city. And we're going to come to Dr. Mulwa and give us general advice, especially across the country, as we trust God that we'll not be infected. What are some of the things we need to keep doing? Because we hear, you know, it keeps changing. We are told masks work, and then some people are saying they don't work, washing hands and all of that. What are some of the sure things we need to keep doing to make sure this thing doesn't catch us? Some general advice to the public. Dr. Mercy.
So thank you, Mr. Mbevi. Let me start with the issue of delayed tests, and I'll also couple this with the issue of contact tracing. Want to begin by saying that yes, globally, as we look at this response, I think we started with a mantra of, you know, test, isolate, trace, and treat, and that continues to be, you know, the approach in terms of the response. But due to constraints when it comes to you know, testing kits and supply chain issues, and also logistic issues, you know, they've come with, you know, certain challenges in terms of how we've been able to effect our strategy, especially perhaps our testing and contact tracing tracing strategy. Yes, it could be better. Yes, we are very well aware of numerous cases of delayed results. Just this morning, I was trying to deal with a few people who have been waiting. I think today they're waiting on day 5 for their results. And part of this is really coupled by a set number of factors and variables. One, while samples were taken, we had challenges with some machines requiring some form of maintenance and servicing. It's important for Kenyans to note that our machines have actually been running for 24 hours since the 1st of March. So every day you can imagine powering through a machine, literally day in, day out for almost, you know, almost 4 months. And so we've had a few issues of breakdown of machines. We've had a few issues where we've had to really reorganize our staff. Some of our staff either are infected. It means that you quickly have to get a new set number of lab technicians deployed. You can imagine, you know, lab technicians are not just hanging by the trees where you capture them and put them in a lab. And so we've had challenges, and yes, we could do better, and we are working to do better. So very well aware of the delays in testing and getting of results. We've had challenges where, by the very nature of how the machines work, and this I just recently discovered myself when I paid a visit to one of the labs to just have a full sort of in-person view of how it all works. And the idea is that you have to collect 96 samples to run in a machine. And a machine cannot run with just one sample. So the idea is that as you run your samples, you have to batch them in groups of 96, add 2 controls, and then do a run. And so a run usually takes 6 hours. And so you can imagine if we are getting our rapid response teams bringing in samples, we have to wait. We have to wait and we have to schedule them and sequence them until we get the batch of 96. So if Machakos has just 3 samples, Machakos might have to wait for a while. If Kiambu just has 10, then it means we might have to wait a bit and have them all batched up. Remember, there's logistics in terms of ferrying the different samples from one end to another to our labs across the country. And then, of course, ensuring that the runs are done and done correctly. And sometimes when you do a run, you might find that at the end of the run, your controls were not put in place accordingly. That means you have to do another run. So now we're talking about 24 hours to 36 hours of a run. So there's a lot of sort of technical delays that we're experiencing, and the cabinet secretary was able to convene a meeting last week with, the whole lab architecture to sort of decide and define what the new approach will be in terms of how we do business when it comes to labs. So hopefully there'll be improvements on that, as well as in contact tracing. And so the other question I think, that you've asked is, and just to demystify, one, masks do work. And I know this was Molo's question, but I'm going to jump in there just because when I hear that, I cringe a bit, because perhaps in terms of hand washing and physical distancing, one of the most pivotal things remains to put on a mask. And that's really, really important. And we've really been trying to churn out communication as to how effective this would be. Wearing a simple surgical mask and wearing it appropriately confers about 40% in terms of protection. If you and I and Bevi are then in a surgical mask together, then now we have 80% protection. And that's why it's important to ensure that you just don't have your mask, but your fellow community members also have masks. And so those are very useful technologies that we really need to embrace as a country. I'm not sure if I've touched, I think the other question, and I think this is actually the most pivotal one that Mr. Wainaina has brought forward. Indeed, it becomes important in the age of COVID-19 to ask ourselves as a country, is our health system ready to protect each and every Kenyan? And really, this is the vision that the president has when it comes to the universal healthcare coverage agenda. And so what we're doing as government is that we are going to be rolling out by September what we're calling the UHC scheme. And the universal health coverage scheme will particularly target poor households in the country, which our current statistics tell us about 40,000 of our households in the country are poor. So this is about 5 million households that would require cover. Cover will be implemented through NHIF, and there's a process already underway. And Dr. Mulo can bear me witness. Different counties are going to be identifying the different poor people, households in their counties. And we'll be able to then issue these households with a cover to protect them, to provide some form of financial protection when it comes to seeking healthcare. That being said, it's important to also really to celebrate our public health institutions, particularly Kenyatta National Hospital and KU and MTRH, who are doing a fantastic job when it comes to COVID-19. And of course, Aga Khan as a private sector partner and collaborator who has been very, very, very helpful in sharing their protocols with us and sort of having, a very good public-private sector partnership. I would say that our public health facilities are more than ready to be able to handle COVID-19 cases. As once upon a time, a practicing medical practitioner, I can tell you taking care of a COVID-19 patient is something that more or less all doctors would be able to do in Kenya. And so we have, well-trained individuals and healthcare personnel across the country who would be able to deal with this. The concerns we have, and Mulo has highlighted them, come in when it comes to critical care. We do need to improve our critical care spaces. We do need more anesthetists, more critical care intervention practitioners and nurses. And I think this was referenced by the last presidential speech on COVID-19. where we're looking to see how we can recruit more critical care workers in that space, because they are a required resource and asset. But just to say, really, I stand confident with our human resources. I myself, have questioned myself, should I get COVID-19? I actually would rather get into KU or KNH as a facility because I know the people who are there and I really do trust their expertise. So thank you. Thank you for that.
Thank you very much, Dr. Really appreciate. We're going to come back to you with some closing remarks, unfortunately, and we'll also ask you to say something over and over again. People have said, why are we the worst placed, the worst hit country in the region? The Tanzania and Uganda and other nations question always comes up. So you will say something as you give your last remarks. But Dr. Mulwa, as you give your general remarks, there's a question about PPEs and protection, nurses and medical staff. I think one of the nurses here has asked, why are we not having enough? And what is being done to ensure that the medical staff are well protected and not being exposed? But also about what general encouragement that we need to have as we work in the counties, that we will be able to lessen the numbers out there.
Thank you very much. You had earlier asked something about asymptomatic cases, and I felt Reverend Wanaina mentioned something about that.
Yeah.
The fact that one does not have symptoms does not really mean that they cannot spread the disease. And in actual fact, all the measures that we are doing, like Dr. Mwangangi mentioned, is the issue of testing, contact tracing, isolation, quarantine, is all to spread to stop the spread of the infection. And therefore, whether one is asymptomatic or symptomatic, they are able to spread. And that therefore means it's important that even when one is asymptomatic, that they are able to take the isolation that is prescribed, whether institutional or home-based, seriously. The one thing that I think and this is purely my own personal observation, is that the disease COVID-19 began and for our country, mainly in Nairobi city and major cities like Mombasa. Mm-hmm. We are now seeing that the disease now move to the counties, the rural counties, where most of the elderly people, most of the vulnerable people are living. And therefore, as we continue to learn more about the disease, I think I'm placing a caution to all Kenyans that we may not have seen the worst part of the disease, because the fact that most of the cases have been asymptomatic in the cities does not necessarily mean it will be so when the disease moves to the rural communities, where there are more older people, there are more people with comorbidities, diabetes, hypertension, cancers, and such diseases. I think for that, I will leave it at that. The other issue that I would like to mention is that one, we are trying as much as possible as a government to ensure that we protect or we bear the cost of management of this disease. And Dr. Mwangangi has mentioned this response is tied to the Big Four agenda, which is universal health coverage. Mm-hmm. And therefore, the one thing that we should not forget is, as the government continues to put in a lot of resources towards COVID-19, mm-hmm. we do not have unlimited resources. Mm-hmm. And therefore, it is the responsibility of everyone to realize that, yes, the government will try as much as possible to reach the vulnerable. And as Bishop mentioned, as Reverend mentioned, when you go to ICU, the government may be able to afford the first 100, the first 200, but I'm certain that we do not have enough resources to have 20,000 people on ICU. We do not even have the capacity. And this has to be accompanied by human resource and all that. Mm-hmm. The issue of PPEs, which was a specific question, mm-hmm. is for healthcare workers. as counties, as national government, we have pronounced ourselves hoarse that PPEs for healthcare workers is not a choice, but is a must. For we do not, and I am a doctor myself, and I keep telling my healthcare workers in Makueni and everywhere else that I go, we are in a state of war. The best army gets its artillery correct before you go to war. You can't go to war barehanded. So the equipment, the artillery that is required to fight COVID-19 by our frontline soldiers, who are the healthcare workers, are PPEs. So I think this country has done extremely well because we are now exporting PPEs. In the beginning of the pandemic in the country, we were getting supplies from almost all the supplies from across the borders. But with the ministry and the multi-sectoral approach, we have very quickly been able to mobilize the internal capacity of the country to produce PPEs. And the PPEs that are being produced in the country, a lot of them, and the ones that have been approved, meet the international standards and are actually better than some of the PPEs that we are importing from outside the country. And therefore, the one thing that we need to ask ourselves, because I have had complaints especially, is to loop in the private sector to be able to ensure that they equally meet. And this comes, of course, with an expense to the private sector in terms of providing PPEs. I would not pretend that PPEs are cheap. Every morning, every healthcare worker who steps inside our health facility, whether a sweeper, a clinician, a mortician, a cook who works in a health facility, nowadays we have to spend money on them. This was not the case a few 4 months ago. And therefore, to just have that surgical mask is close to 70-80 shillings per person. And you are talking about an establishment like in Makueni of close to 2,500, of more than 2,500 healthcare workers. That means you are talking about 2,500, which is about 2.5 million Kenya shillings or thereabout, 250,000 Kenya shillings per day being spent on PPEs. So this conversation, as we continue, it's expensive. The private sector needs to be brought in. We need to continue with the innovations that we have done as a country, so that as we produce more, the cost of PPEs goes down. We also had an issue with global logistics chain, and Dr. Massimo Wangangi mentioned this, that yes, we also should look at our country, not just as Kenya. We are in a global society, and therefore what affects the whole world? Like when we need materials for making PPEs, these materials are required not just in Kenya, but they are required in all the territories of this world. And therefore the prices go up, and sometimes the supply is not as fast as you would want them to be. And therefore, as I conclude on this matter, is to say, the government will continue to do its best. The Ministry of Health will continue to issue guidelines in the best interest of everyone to ensure that we protect our citizens. And again, I go back to this point that every citizen must play their role, which is to ensure that they take responsibility for their actions. I am very disappointed when I go to markets and I find Kenyans who are not putting on masks, Kenyans who are not washing their hands, Kenyans who are not sanitizing, Kenyans who are not adhering to the transport protocols that have been issued, and they are overloading matatu, and they claim the problem is the matatu, and you are getting to a matatu, the seating capacity should be 60%, and you are an excess person, not even 100%. They are carrying over 100. This is a problem that cannot be solved by government, because the government will not be where every matatu is. The government will not be where every stage is. When we talk about self-regulation of places of worship, these are a responsibility for every single Kenyan to ensure that they take responsibility, because if we don't, then we should be ready to lose ourselves or lose our loved ones. Thank you, Reverend.
Thank you very much, Dr. Molwa. Thank you for those of you who are still continuing to watch. We are concluding. As we promised you, we will be back next week. Thank you for many of you have said this is very informative. A lot of appreciation to you, Dr. Massey, for the daily updates and also the things that you have shared. The doctors, there's a lot of conversation here that you have really added to the knowledge of Kenyans. We have our friend from Tanzania as well, Karibu Sana, Maxwell. And thank you for joining in. A lot of good questions, but maybe Dr. Mwangi, Dr. Masi Mwangangi will come to you as you give your last words, and then we'll come to Reverend just to say some comforting words from a spiritual perspective as he says his last words and says a prayer to us. But thank you to all of you that have been watching, and many questions. Unfortunately, we were not able to get to them. But Dr. Massey, they are asking several people. The CS said it's, is it 1,000 for the test? But people are being charged 5,000, 10,000. What can be done about that as you give your final remarks?
Yes, sorry. Indeed. Sorry, I think that's unmuted now. So yes, indeed, the CS did mention that the test would be coming down to 1,000. And this will be rolled out really shortly. In fact, I'm aware that some laboratories who are to conduct the test at no cost. And what we will do perhaps is communicate this when we move forward. And as Mola has said, it's really important for Kenyans to understand that conducting the whole affair of COVID-19 is extremely expensive. And I've seen people saying, you know, they see the billions and perhaps they imagine that it is just teas and samosas at the Ministry of Health, which is really not the case. It's important to note that for us to be able to actually conduct 100,000 tests, you actually need more than about, you know, 2.5 B to be able to actually conduct 100,000 tests. Remember that, you know, these tests come from two sample areas, you know, the nose and the throat, and that there are instances where we need to do repeat tests. So every time we say it's 100,000 tests, it's not just 100,000 people tested. It is a very expensive affair. And then, of course, not to mention the PPEs, the human resources that are required, but also external from the Ministry of Health. Remember, this is a response that's coordinated across government, Ministry of Interior, Treasury, and many other participants. Water, who need to put water points, extremely expensive affair. So really to remind us all of that individual responsibility. I feel it's important to also define and note that I don't think, and we are always literally watching and always having teams, you know, our policy analyst teams are watching and trying to see what the response looks like in different countries across the world. No one country has been able to perfect response in terms of COVID-19. And it is important to appreciate, and sometimes as government, we may perhaps be shy of celebrating some of the successes that have been had in this country. And just to mention a few, many might not know, I've seen different countries being celebrated for putting up units. Kenya in of itself was able to put up 500 beds and 60 ICU beds in just 2 weeks. And that's remarkable. Nobody has ever been able to set up such an institution. And that's KU. And we did that just in under 2 weeks, and we're able to deploy staff and have it up and running, amongst numerous other successes that we've had as government in terms of this COVID-19 fight. But that being said, there's also an element, I think, of fear that is creeping in, particularly today and yesterday when we announced 23 deaths. And, you know, every time, you know, there's an increase in the number of deaths, there's a lot of backlash, there's a lot of fear. But it's important to always note that fear always comes from a place of inaction. And because this fight is our fight, this is government's fight, but this is also your fight, it's important to then question, where is your fear coming from? I would be a bit disappointed if you are afraid and anxious, but you're not masking. If you're afraid and anxious, but you're not washing your hands. If you're afraid and anxious, but you're jumping into that matatu as the 14th customer, you know. If you're afraid and anxious, but you're crowding up, you're taking your children to the supermarket and observing measure. Really, at the end of the day, it means that you are also duty bound. and that you have a responsibility, and really we can't overemphasize that you do have a part to play in this. And so partner with us, partner with government, trust your government. There are tons and tons of success stories, and perhaps when all this is said and done, you'd be able to celebrate some of the things that have been put underway. But then, of course, more remains to be done. There's an important question that was asked earlier: are we overwhelmed? And interesting to note that today we have about, say, 50 people who are in ICUs across the country, but we have about 400 beds that are empty, ICU beds designated for COVID-19. They're empty, they're lying idle. And that perhaps is an attribute to the success that government is having in terms of this response in the grand scheme of things. And I think through the COVID-19 response, we've been very transparent, very accountable in terms of how we're navigating and trying to steward this response. And it becomes important to really not collapse under the shroud of fear, and to also play a part in this. So thank you. I'm looking forward to Wainaina's comforting words. I think I need them as well.
Well, thank you very much, Dr. Mercy. A lot of good words for both of you doctors. Yeah, you seem to be loved a lot by Kenyans and non-Kenyans, and your response as well. And a lot of people saying, Dr. Mercy, that we appreciate that you have confidence in the public systems. And so that means a lot to a lot of people. Many of you have stuck with us. We have gone way beyond time. We will continue this next week. Thank you for your questions. Many of you are still waiting for your questions to be answered. We have noted them. We're going to pick them up next week, but we appreciate all of you. Just to remind you that we have different programs that we do as Transform Nations. For moms, we have Intentional Moms. For men, we have Man Enough, the XY Journey. Lots of you have done it. We have EZA, which is the equivalent of Man Enough for the ladies. And we have been grateful during this season to see a lot of you getting to all of those programs, thousands of you. So we're continuing that online, and the information is on our page, Transform Nations. Please feel free to let us know if you want to get involved. We are mentoring boys, Boys to Men mentoring program that is starting this weekend. And in case you have boys 7 to 17 that needs mentoring to attend some classes, which are very helpful, you're welcome. So Reverend, you could finish for us. Time just flew, lots of good conversations. Please give us a word of encouragement, the provost that you are, and you may say a short prayer for us as we conclude. But we're so grateful. A lot of people responded to your story, and they said, and we want to talk about stigma. I think Dr. Mwangi next week was Dr. Mercy, Mwangangi. We'll start there next week, and Dr. Mulwa, how to deal with this stigma thing, even from perspective of religion. So Reverend, please go ahead and end for us with a word of encouragement. Reverend, I think you need to unmute you. Okay, now you are. Okay.
Thank you.
All right.
As I give a word of encouragement to all Kenyans, there were days of ignorance where nobody would have judged us much when we were ignorant. But with all the information we are getting, surely we can't remain ignorant. We have to confront COVID-19 pandemic with information. I know we'll be talking about the stigma, but stigma is confronted by facts. When you know the truth, then stigma reduces. And we've learned that with other pandemics. And so I'm asking Kenyans, the government has done its best. It is very sad to see Kenyans joking with the daily announcements that are done by the Ministry of Health and saying it's a public show. Please, Kenyans, I know sometimes the government has failed us in the past, politically especially, but I think this is not a political fight. This is about your health. Don't be an ignorant person. During this time, I've seen people self-medicating, as Dr. Mulwa said. I've also seen others being very spiritual, overly spiritual, that they suspend their reason in the name of their faith. I think it is good to have a balanced view of life. You have the information. Please use the information. If you are unwell, seek medical attention. When you hear 23 people have died in a day, it's not just individuals. These are families affected. These are communities. And I felt that when I became sick, my family was affected. The cathedral that I serve was affected. My parents were affected. So the effect of COVID-19 is not just on individuals that are mentioned every day. It's about the communities that are affected. But let me say this as a man of faith. I know God is greater than coronavirus. He's sovereign over everything. And coronavirus will come to an end. We have power to pray, and we are praying, but we are praying with knowledge, not with ignorance. God will save our nation. If you compare what is happening in Kenya with what happened in China and what happened in Europe and America, you realize God has been gracious to us. So please play your part. God will play his part, and together we'll save ourselves from this calamity. Otherwise, we are not preachers of hopelessness. We are preachers of knowledge, truth, but also hope that everything is not lost. If I'm speaking to you today, it is a sign that actually you can come out of it. Just seek medical attention as early as possible. Let me pray with you. Heavenly Father, we acknowledge your sovereignty over each one of us. We acknowledge your sovereignty over the nation of Kenya. And you placed us here with a purpose. And as you say in Acts chapter 17, you have placed people in faces of the earth that they may be able to seek you and find you, although you're not far away from us. Father, we pray that as the government does its part, as Kenyans give their best, that you will show your mercy on this nation, that you will show the power to deliver us from this pandemic. And we pray for families that have been affected, especially by death, that you may have mercy on them. I pray that they may not feel you abandoning them. Show them your mercy through you, the presence of your Holy Spirit. Heal their wounds and restore them. Restore our economy. Restore many people who have been affected. And let one day each one of us give a testimony of your grace. Be with us tonight. In Jesus' name we pray. Amen.
Amen. Amen. Thank you very much, Reverend. Thank you, Dr. Massey. We so appreciate your coming in. Definitely, people have asked that all of us come back next week. So we would love to finish. There are many questions. We have noted them. So we will start right there next week and be able to finish. Dr. Mulwa, thank you for making time and being here. We so appreciate your answers as well. Lots of celebration and from many people say we are well informed, we will behave better. So thank you, everyone. We're sorry to all of you. We have gone way past time. I think it's just the way the subject is today, but we appreciate everyone. Thanks for joining in, the thousands of you from both Kenya and beyond. We look forward to seeing you next week at same time. We will narrow down to a few questions next week, and we'll finish a lot earlier than this. Thanks again, everyone. We so appreciate, and we're praying for government as you continue all the good efforts. Have a good night, and God bless you.
Thank you, and have a good night too.
All right, thank you. Thank you. We appreciate everyone.